Good evening, everyone. Welcome to another session of academics from Ankura Group of Hospitals. I am Dr. Vinay, consultant neonatologist, Ankura Hospitals, LB Nagar, Hyderabad. Today, the topic of discussion is acute deterioration of neonate on a ventilator, the systematic approach. To chair the session, we have two eminent faculty, Dr. Amit Gupta, Dr. Nishat Plakal. First, I would like to introduce Dr. Amit Gupta. He is a clinical director of neonatal medicine, John Radcliffe Hospital, Oxford, divisional lead, international workforce, Oxford University Hospitals, NHS Trust. He is a patron, Neonatal Transport Forum of Sri Lanka. He is a recipient of many awards. To name a few, he is a recipient of Lifetime Achievement Award, Neonatal Forum of India 2015, BMJ South Asia Award 2018. His special interests are effect of preterm birth on neonatal lungs, effect of culture on performance of doctors. Today, welcome, sir. Uh, Today, we also have Dr. Nishat Slakal, sir, to chair the session. Sir has done his pediatric residency from PGH Chandigarh. He has done his residency and fellowship in neonatal and perinatal medicine from University of Calgary, Canada. Presently, he is working as associate professor in neonatology department, JIPMER. He has at least 35 publications in index journals and 20 book chapters. His areas of interest are neonatal hypoxic ischemic encephalopathy, continuous quality improvement. Welcome, sir.
Thank you, Vinay.
To speak on the topic, we have Dr. Chanchal Kumar, consultant neonatologist, Ankura Group of Hospitals, Banjara Hills, Hyderabad. He has at least 5 research publications and contributions to protocol books chapters. He is a recipient of V. Balagopal Raju Award for Best DM Thesis and Gold Medal for Outstanding Paper in NeoCore 2020. Now, I would like to request Dr. Amit Gupta to say a few words on the topic.
Thank you very much for inviting me to this meeting, and thank you Veera for emailing me about this. I hope this will be a good session. I think the topic is pretty interesting: the acute deterioration of a newborn on the ventilator. And there are two things I think trainees get scared, and I remember my time as a trainee. One is you're stuck in a delivery room with a preterm baby and you can't intubate for some reason. I mean, that's the stuff of nightmares. And of course, when you have the second one is when you've got a baby who just acutely deteriorates on the ventilator. And the first thing that when that happens is a sense of panic. You know, what do I do next? And if you read things, it's very easy when the event is over, you can think in hindsight what should have been done. But if you've got a systematic approach that is built into your thinking, then some of the anxiety can be taken away, and then you can just follow that systematic approach. And I think that's really important, because this is something which is knowledge applied under pressure, under a lot of action. And so therefore you need a clear head, you need a systematic approach to it. So I'm very glad that this is something that Dr. Chanchal is going to talk about. I'm looking forward to listening to him. Dr. Nishad, is anything you would like to add to this before we let Dr. Chanchal Kumar present his talk?
Yeah, I thank you, Vinay and Dr. Chanchal, for inviting me. And I'm really glad that Chanchal is presenting this. Until recently, he was working with us in a very busy unit, one of the busiest in the country, maybe. And the topic he's talking about is something that's very common. And like Dr. Amit was saying, systematic approach really helps in this situation. One of the things about that I have noticed when working in the NICU is that in our country, unfortunately, there are still many unexplained deaths of babies on the ventilator. So it's not unusual for me to walk into the NICU one morning and the resident tells me that the baby suddenly worsened and died. So that kind of thing I mean, it's unfortunate, but that kind of thing doesn't happen too commonly in a Western setting. So I always wonder, what is it? Is it because we don't have enough staff to monitor the patient? Or is it because we don't do enough simulation? Or is it because that line of systematic approach to things isn't inculcated in our residents enough? Is that so? This is one of those situations that is unfortunately fairly common in, especially in busy units, and one of the situations where we can make a difference, as Dr. Amit was saying, with a systematic approach. So I'm really looking forward to hear Chanchal talk about this. Couldn't
And
have asked
I
for a
think,
better person.
thank you. I really like the, I mean, I think that's such an important point you've raised. And it's something that has come across to me as well when I was in Chennai a few years ago, when one of the doctors told me about this, that, often you find this, and this usually happens overnight, that you come in the morning and that doesn't, and you find that the baby didn't survive. And I would be pleased, I would be eager to know once the talk is done is what Dr. Chanchal thinks about it. But I think it would be an important point to discuss after we have listened to him, because it is something that is quite important to tackle. So I think we'll let you start, otherwise we'll hog all your time, Dr. Chanchal. We'll let you start.
Thank you, sir, for those kind words and setting the plot, sir. And thank you, Dr. Vinay, for the kind introduction.
Thank you, sir. Before going through, I would like to request all the delegates to post questions in Q&A box. Thank you. Over to you, sir.
So, Dr. Vinay, is the slide full screen?
Yes, sir. Yes, sir. Yes, sir. Full screen.
Yeah. Okay. So, thank you, Dr. Vinay. So, a very good evening to all. I'm honored to deliver a talk on this very much relevant topic in our day-to-day practice in NICU. The mechanical ventilation is an important tool used in NICU, even despite of widespread use of non-invasive respiratory support technique these days. And putting a baby onto a ventilator is not free of complication. If you see the large study on CPAP also, in almost more than 60% of the extreme preterm neonates required ultimately the mechanical ventilation. So this is not going anywhere. And this is one of those conditions, this acute deterioration of a neonate on ventilator. This is one of those conditions which all of us as a neonatologist or pediatrician do not want to happen at all. So putting the baby on mechanical ventilator is not free of complication, as sir said, and this it can be either acute complication or long-term complications. But anticipation and the early diagnosis are the two important aspects for the management of these conditions. If as we say, this acute deterioration of a neonate, actually this is not acute deterioration, and most of these conditions do not happen all of a sudden. So there is a process always, as sir said. So there is a risk factor. It leads to worsening of the process, and then there is acute deterioration, and the baby manifests with clinical signs and symptoms of acute deterioration. So most of these conditions do give us some time to pick up these individual conditions and manage and prevent the deadly desaturation and bradycardia episode. So it is this time period where we all want to make an early diagnosis and prevent the acute deterioration itself. So there comes the role of anticipation and early diagnosis. And in next 40 minutes or so, the discussion is focused mainly upon the anticipation and the diagnosis of these conditions. The management of individual conditions is actually itself a huge topic, and we are not going to discuss over here. I have used few of the illustrations from Professor Satyan's papers just to simplify the topic. So starting with the two case scenarios, case one, This baby is a 2-day-old neonate born at 26 weeks of gestation, has sudden onset desaturation and bradycardia. The nurse says that she was changing the diaper, and when the baby started desaturating, and despite increasing the FiO2, this baby continued to deteriorate. And monitor is displaying the saturation as 50% and the heart rate at 70 per minute. So this is the pulmonary graphics. So we can see here 3 scalar waveforms: the pressure waveform, flow waveform, and the volume waveform. The pressure waveforms looks regular. If we see the flow waveform, there is only inspiratory flow wave, and there is absence of expiratory flow wave pattern over here. And in the volume waveform, we can see that there is abrupt decline from the peak to the baseline, suggesting almost 100% leak. And if you see the exhaled tidal volume, this is very, very low. This is just 1.2 ml. And the ventilatory rate is 102 per minute. That is suggestive of auto triggering. So what is this condition we are dealing with? So let's see the examination findings. So on examination, there was no obvious obstruction, and the endotracheal tube looked secure at the mouth. On auscultation, there was minimal chest movement, and air entry sounds louder over the stomach as compared to the lungs. So this is basically a case of accidental extubation, and the management would be the removal of endotracheal tube, mask ventilation, and reintubation. Then baby improved. Let's move on to the second case scenario. This is a 8-day-old infant born at 25 weeks of gestation, and this baby has an increasing of FiO2 requirement. This baby is desaturating even on 100% of FiO2. The baby was reintubated just 4 hours prior, following an accidental extubation. The nurse says that the baby has sternal retractions, and the monitor is displaying 100% of 80% oxygen saturation on 100% of FiO2. So again, looking at the pulmonary graphics, the pressure waveform is regular over here. We can see that the flow waveform and the volume waveform both are reduced in size. And if you see the display panel, the exhaled tidal volume is very low. Similarly, this ventilation is also very low. And the resistance is quite high. Normal resistance in a normal neonate would be around 20 centimeter of water per liter per second. And this is quite high, 239. So what is this condition we are dealing with? So on examination, there was no obvious obstruction of endotracheal tube, but the tube appears to have slipped to 8 centimeter at the lips. Mind you, this baby is 25 weeks of gestation, and the endotracheal tube length at fixation based on nasotragus length comes out to be around 6.5 centimeters. So definitely this tube is too far in the trachea. On auscultation, there was a reduced air entry on the left side, but good air entry on the right side. So this is a case of unplanned advancement of endotracheal tube. Basically, the tube has gone too far in the right main bronchus, and after pulling back the endotracheal tube, the baby improved. So these two conditions, as sir said, are very common in our day-to-day practice in an NICU, and these are kind of one of those nightmares. So the question is how to prevent these conditions and make an early diagnosis. So the classic teaching is DOPE. We all of us have learned this DOPE approach to diagnose these conditions. This DOPE stands for displaced tube, obstructed tube, pneumothorax, and equipment failure. There are many other approaches also, but now the focus is mainly on the anticipation and early diagnosis to follow the systematic approach by using newer available tools. And at last, this quality improvement initiative, these studies are actually quite helpful in reducing the incidence of these problems. There are other approaches also, like DOPE-SIP approach, where SIP stands for sepsis, intraventricular hemorrhage, and PDA. So I'll be discussing one such approach, which is called BOLD-PEEP approach. This is just an extension of DOPE approach. This stands for bad or worsening lung disease, obstructed endotracheal tube, long endotracheal tube. This long endotracheal tube means the tube has gone either too far in the trachea or it's too high in the trachea, both conditions. Displaced endotracheal tube or extubation, accidental extubation, pneumothorax or other air leak syndromes, equipment failure, and equipment patient asynchrony. So the systematic approach we are talking about comprises of 3 steps. So anticipation of the complication is the foremost important step of the systematic approach. And this should start as soon as the baby is put on mechanical ventilator. The second step is information collection from the various sources, including historical aspect, nursing chart, monitoring chart, progress notes, as well as pulmonary graphics, ventilator parameters, various trends, and investigations like recent blood gas values or X-rays. And finally, the third step is analyzing the data and reaching to a conclusion. So as I said, that anticipation should start as soon as the baby is put on mechanical ventilator, and it should be part of daily assessment, and we should discuss this during our day-to-day rounds. So this discussion includes the natural history of the underlying disease per se, and what happens to the disease when the baby is put on mechanical ventilator. We should also discuss the anticipated duration of mechanical ventilation, then whether there is any need for other organ support like cardiovascular support, and the likely complications, including acute complications or long-term complications. The various informations to be collected from sources like historical aspect, the monitoring data, nursing feedback, doctor's progress notes, the ventilation parameters, pulmonary graphics, and various trends on the monitor, and the investigation including recent blood gas and X-rays. So there are 3 major culprits to make this happy infant sad. These 3 are either this could be equipment related, or this could be intratracheal tube related, or this could be related to the infant itself. So let's see the equipment related factors. So this could be because of either user error when the ventilator settings are actually inappropriate. So there is inadequate delivery of pressure and tidal volume, which leads to the worsening of underlying disease and finally acute deterioration. If your ventilator settings are good and appropriate, this could be because of your sensor malfunction also, which will lead to the delivery of insufficient ventilatory rate and pressure. Or this could be because of mechanical factors straightforward, like disconnection in the circuit or a large leak. The endotracheal tube related factors could be either because of obstruction or could be because of displacement of endotracheal tube. So obstruction can be either internal or external. So internal obstruction can be because of either blood clot in case of pulmonary hemorrhage, or this could be because of secretions when there is associated infection or consolidation. The obstruction can be external also when there is any kink in the tube, or there is some external compression, or this tube has gone too far in and there is angulation at the carina level. So these factors can cause obstruction externally. This tube related factors could be because of displacement of the tube also. So the displacement could be either upwards when the tube is too high in the trachea or accidental extubation, or the tube is too far down in the trachea going into the right main bronchus and ultimately leading to single lung ventilation. The third culprit is infant related factors. So we can categorize these infant related factors into either respiratory cause or into the non-respiratory causes. So the respiratory causes include either the worsening of lung disease, there could be associated PDA or PPHN, or there could be associated complications like bronchopulmonary dysplasia or any Ehrlich syndrome. The non-respiratory causes include associated infection, which may lead to consolidation. There could be hypotension or acute blood loss, severe grade of IBH, metabolic acidosis, acute abdominal condition, which will actually split the diaphragm and will worsen the respiratory mechanics, or this could be because of seizures. So next comes the preparedness. So this is a part and parcel of the anticipation. So this picture I have borrowed from a ventilation workshop. Whenever the baby is put on mechanical ventilator, all the equipments needed for the resuscitation should be kept arranged bedside. This includes the device for positive pressure ventilation, either self-inflating bag or TPC resuscitator, appropriate size mask, endotracheal tube, oxygen tubing, suction catheter, and etc. So the basic rule whenever there is acute deterioration of a neonate on ventilator is to disconnect the baby from the ventilator and start positive pressure ventilation, either by using self-inflating bag or TP's resuscitator. Use the same setting whatever the baby was on the ventilator, and then look for the chest movement. So if there is no chest movement, then based on the auscultatory findings, we can narrow down the diagnosis. So if there is no air entry, this could be because of complete tube block. If there is unequal sound, then this could be because of pneumothorax or other air leak. If the breath sound is more prominent over the stomach as compared to the lungs, then this could be because of accidental extubation. Or if we are appreciating wheeze, then this could be because of bronchospasm. If the chest movement is adequate and there is improvement on positive pressure ventilation, whatever we are providing, then based on the requirement of pressure, we can narrow down the diagnosis. So if the pressure requirement is more, this could be because of either a worsening lung disease or because of partial tube block. If the pressure requirement is same as the setting on the ventilator, this could be because of ventilator failure. But if there is no improvement on positive pressure ventilation, then this could be because of various causes related to the infant, either respiratory causes or non-respiratory causes, as mentioned in the previous slide. So in next few slides, we shall be discussing the bold PEEP approach. So the discussion will be based on the historical aspect, the examination findings, various charts, including monitoring chart and nurses feedback chart, the recent blood gas value, the pulmonary graphics, and the X-ray findings. So in case of bad or worsening lung disease, in history, we may find that there was no antenatal steroid coverage, or the coverage of steroid was incomplete. There could be requirement of higher FiO2 since beginning, or there could be associated premature rupture of membrane suggestive of infection. On examination finding, we may find poor chest movement and reduced air entry bilateral. In the charts, we may find rising FiO2 requirement, multiple desaturations, and the levelity of the baby for the oxygenation. The blood gas may show respiratory acidosis. In the pulmonary graphics, this is very useful. This may display low compliance, high resistance, or the flow waveform will be blunted, or the minute ventilation and the axial tidal volume will be reduced. In the X-ray, we may find the severe or bad respiratory distress syndrome, low volume lungs in case of pulmonary hemorrhage or severe RDS, or associated consolidation if there is associated infection. So in this X-ray, we can see that there is a bilateral whiteout low volume lungs with air bronchogram, suggestive of severe RDS. And if you see in the pulmonary graphics, you may find the reduced compliance. So what are the remedial measures for this condition? So we have to optimize the PEEP to keep the lungs at functional residual capacity level. We can use open lung manure for the proper recruitment. We may increase the pressure. We may consider the administration of surfactant if not given already, or the subsequent dose of the surfactant. If there is pulmonary hemorrhage, in case of pulmonary hemorrhage also, we may find this kind of whiteout lung, and because of secondary inactivation of surfactant, the compliance will be low. So this has to be managed accordingly. There could be associated PPHN also. I'm not going to talk about the pathophysiology and the management of PPHN, but functional echocardiography can be very much useful to make a diagnosis of the underlying condition. So in this slide, we are seeing that based on atrial and PDA level, PDA shunt level, the underlying diagnosis can be made. So the black bar is basically the ductal shunt, and the blue bar is atrial shunt. So in case of normal neonate, both shunts will be from left to right. But this can be there in the baby with parenchymal lung disease without pulmonary hypertension. If both shunts are from right to left, then this could be because of PPHN. And we may find some other associated findings also, like bowing of interventricular septum towards left side, or associated tricuspid regurgitation. If the shunts are in the opposite direction, then this could be because of ductal dependent circulation, either ductal dependent pulmonary circulation or ductal dependent systemic circulation. So this may be helpful in the management also, as we can see that nitric oxide is the modality of choice in case of E patient, but this is contraindicated in case of duct dependent systemic circulation. The extubation failure in extreme preterm neonates. This is not a part of bold PEEP approach, but we need to discuss over here because this is kind of quite commonly seen if baby is extubated prematurely and getting reintubated in the immediate extubation period. What is the optimal timing to decide for extubation? So there are several factors associated with the extubation failure in extreme preterm neonates. This could be either because of CNS related, this could be because of either severe grade of interventricular hemorrhage, or because of immature respiratory center, which may lead to recurrent apnea episodes. This could be because of either immature collapsing airways like laryngomalacia or tracheomalacia. The lung is already in the immature development stage. There could be this could be because of thoracic problems, including soft pleural thoracic case. This could be because of either weak intercostal muscles or diaphragmatic muscles. Surfactant deficiency is already there. There could be associated PDA, or there could be associated injury to the airway because of endotracheal tube itself causing either vocal cord edema or subglottic stenosis. So the extubation in the extreme preterm neonate should always be planned, and it should be based on the optimal timing of extubation. We should always follow a checklist protocol for deciding of the extubation in extreme preterm neonates. Because if we are extubating at optimal timing, then we will lead to a successful extubation. But premature extubation will lead to extubation failure because of various reasons mentioned in the previous slide, and ultimately will result to the repeated intubation and its own consequences, like there could be bradycardia, hypotension episodes, and the prolonged ventilation requirement. While if the ventilation is prolonged, then it has its own consequences, like ventilator-induced lung injury, because of various mechanisms like barotrauma, volutrauma, rheotrauma, or oxytrauma, or atelectrotrauma. And this may lead to long-term complications like neurodevelopmental impairment or bronchopulmonary dysplasia. So always the extubation in the extreme preterm neonate should be planned. Next one is obstructed endotracheal tube. So in the history, we will find there is a history of copious secretions because of either associated infection or because of pulmonary hemorrhage, which is leading to blood clots in the endotracheal tube. And there could be variable FI2 requirement in the history part. On the clinical examination, we may find variable chest movements and reduced air entry. There could be associated crepitations or wheeze if there is a associated consolidation or pulmonary hemorrhage. The charts may display rising FI2 requirement, multiple desaturation episodes, and requirement of frequent suctioning. Blood gas may show respiratory acidosis, and if there is associated pulmonary hemorrhage, then there could be a mixed acidosis also. The pulmonary graphics may show variable compliance and resistance based on the underlying problem. The flow waveform may be blunted. X-ray may be totally non-specific, or it may demonstrate the associated consolidation or pulmonary hemorrhage findings. So if there is a airway obstruction, the pulmonary graphics may be quite helpful in the making of early diagnosis. So in the flow waveform, we may see that the inspiratory flow wave is normal, but the expiratory flow wave, the peak expiratory flow rate will be reduced, and the expiratory time will be prolonged. Similarly, in the flow volume waveform, we may see that inspiratory flow is normal, but then in the expiratory flow, there will be reduced peak expiratory flow rate and the scooped out pattern of this flow expiratory flow waveform. So these pulmonary graphics are quite helpful in making the diagnosis of obstruction of endotracheal tube. Next comes the long endotracheal tube. So as I discussed earlier, long endotracheal tube, we will be discussing both either the endotracheal tube is too far down in the trachea or this is too high in the trachea. So in the history part, we may find that baby never settled on the ventilator after since the baby is intubated. And there could be history of endotracheal tube which is too far down found on X-ray. On clinical examination finding, we may find poor chest movement or reduced air entry on the left side, and improving after the pulling out of endotracheal tube. The charts may display rising FiO2 requirement, multiple desaturation episodes, and the lability of the baby. The blood gas may display respiratory acidosis. The pulmonary graphics may show higher resistance, blunted flows, and volume, as we saw in the second case scenario. In the X-ray, we may find the endotracheal tube too far down in the trachea. There could be asymmetry of the chest. There could be hyperinflation on the right side, and there could be right upper lobe collapse also. So this X-ray is suggestive of the endotracheal tube, which is too far down in the trachea and causing right upper lobe collapse. If the endotracheal tube is too high in the trachea, then this will lead to a leak in the circuit. So in the flow volume loop, we may find air leak, and in the flow waveform also we may find leak in the circuit. Next comes the displaced endotracheal tube, also or accidental extubation. So in the history part, we may find that there is sudden desaturation or no response to the positive pressure ventilation, either by TPs or self-inflating bag. On examination findings, we may find there is no chest movement on air entry, and there could be audible leak, and there could be no color change in ETCO2 sensor. Charts may display that baby was quite stable before the acute event, and there could be history of recent handling of the baby, and after that baby is quite active. The blood gas may be absolutely fine before this acute event. The pulmonary graphics may show no expiratory flow wave and incomplete loops. There could be alarms for minute ventilation and tidal volume. This we saw in the first case scenario. The X-ray may show the endotracheal tube seen on the right side of the trachea or the left side of the OG tube. So the X-ray is chest X-ray is the investigation for the endotracheal tube position confirmation, but point of care ultrasound has been shown to be useful for the endotracheal tube tip position confirmation, and this is basically the suprasternal view. If you put your high frequency probe on in the suprasternal notch, you may find this with probe facing 12 o'clock, then you may find this suprasternal view, and arch of aorta will be visualized. This is the endotracheal tube over here, and this is arch of aorta. So this distance, we have a nomogram based on this Indian study, and the distance between that ET tube and ET tube tip and the arch of aorta will be around 0.7 to 0.8 centimeter in case of babies with birth weight less than 1.5 kg, and this could be around 1 centimeter in case of babies more than 1.5 kg, and this position is basically just below the carina level. So this point of care ultrasound is quite useful in the position confirmation of the endotracheal tube. The advantage is this is free of radiation, and we may repeat it many times. But it needs some expertise, but it's a kind of easy bedside approach when where we can confirm the ET tip position. Next comes the pneumothorax or air leak syndrome. So in the history, we may find that there is no antenatal asteroid coverage or incomplete antenatal asteroid coverage. There could be history of moderate to severe respiratory distress syndrome or pulmonary hypoplasia. The administration of surfactant was late. There was a requirement of high pressure initially. And if the acute event has occurred already, then there will be a sudden drop in the blood pressure. On the clinical examination finding, we may find asymmetry of the chest shape, movement, as well as air entry, and the transillumination test will be positive. The charts may display sudden change or deterioration of the baby. Blood gas may show worsening respiratory acidosis. The pulmonary graphics will display air trapping before the event, the overdistension and the air trapping before the event actually. And once the event has already occurred, then there will be large leak and autocycling, and reduce axial tidal volume as well as minute ventilation. X-ray will demonstrate pneumothorax or other air leak. So let us discuss this PV loop over here. So we all know that the PV loop is S-shaped curve, and it has 3 zones. The flatter zone at the beginning is basically zone of atelectasis. The flatter zone at the end is basically the zone of overdistension. And this is the mid zone, which is the safer zone for ventilation. So if we ventilate in these two extreme zones, either in the zone of atelectasis or zone of overdistension, there is very little change the volume, and it requires more change in the pressure. So that's why these zones are not safe. So even this zone of atelectasis also can lead to a rupture of alveoli because of a repeated opening and closing of the alveoli, and because of shear stress, it may rupture and may lead to air leak. But more commonly, this happens in the zone of overdistension when there is a risk of polytrauma and barotrauma. So when there is a high intraalveolar pressure or air volume, this could lead to rupture of alveoli. And based on dissection of air into various cavities, one may find pneumothorax, pneumomediastinum, pneumopericardium, subcutaneous emphysema. If the air is dissected into the pulmonary interstitium or perivascular sheath, then it may lead to pulmonary interstitial emphysema. One may find systemic air embolism also because of dissection of air into the pulmonary vessels, or one may find pneumoperitoneum also. So this slide displays the incidence of pneumothorax based on 3 large databases from the US, the Europe, and the Australian neonatal network. So we can see here that the incidence of pneumothorax is inversely related to the gestation at birth, with almost 13 to 15% in the babies under 24 weeks of gestation. Similarly, the incidence is inversely related to the birth weight also, with the incidence of pneumothorax almost 4 times higher in babies with the birth weight of less than 1,000 grams as compared to babies with birth weight between 1,500 to 2,000 grams. So before the acute event, one may find some clinical clues, and one may make early diagnosis. So on clinical examination, we may find the features of hyperinflation, and on X-ray also this may display as hyperinflation before the acute event. There are certain other clinical clues also before the actual event of desaturation and bradycardia in case of air leak syndrome. So there could be paradoxical symmetry of the chest. So this is nothing but when you turn the in normal neonate, when you turn the head to one side, the hemithorax on that side will be less prominent as compared to the other side. But in case of pneumothorax, you may find that this is as prominent as compared to the other side. There could be pseudo bradycardia also. This is because of reduced cardiac output because of tension pneumothorax. So on auscultation, the heart rate will be normal, but on pulse oximetry, you may find that heart rate is in the bradycardic range. So this is basically pseudo bradycardia. There could be low voltage in the ECG trace. Pulsus paradoxus is basically exaggerated decline in the systolic pressure with inspiration, and one may appreciate it clearly in invasive BP monitoring. There could be associated other signs and symptoms also, like air hunger, including gasping or anxious faces. There could be shifting of mediastinum, so diminished or shifted breath sounds. There could be chest symmetry also. There could be severe hypotension or subcutaneous emphysema. The liver and spleen could be easily palpable in case of shifting of mediastinum. So as I said earlier, before the acute event in the air leak syndrome, one may find this overdistension in the pulmonary graphics. So this is beaking in a pressure volume loop in case of overdistension, and one may find air trapping in the flow volume loop before the acute event in case of air leak syndrome. But once the acute event occurs, then one may find the leak in the circuit. Trans-illumination test is quite sensitive and important test, bedside test for diagnosis of pneumothorax with the reported sensitivity of almost 87 to 100%. But it could be false positive in pulmonary interstitial emphysema or pneumomediastinum. There are various factors which actually interfere with the trans-illumination of a pneumothorax, like chest wall edema, or if there is chest wall dressing or tape, or room lighting is quite bright, or the transluminator light is not functioning well. So these are various factors when there could be problem with the transillumination test. But otherwise, it is quite sensitive test, and it can be repeated even you have put the chest drain to for the pneumothorax to see whether your chest drain is working or not. So on X-ray, one may find a collection of air between parietal pleura and collapsed lung, as demonstrated in this illustration. And there will be a sharp margin of the cardiac shadow. One can find this sharp margin of cardiac shadow, and there will be shifting of mediastinum to the opposite side. If the air is dissected into the pericardial space, then this may result into the pneumopericardium. This can be either isolated or this can be associated with the pneumothorax also. So on X-ray, one may find air shadow all around the cardiac shadow, including the inferior border of the heart. So you can see here that inferior border of heart also will show the air shadow. But in case of pneumomediastinum, this air will be seen around the cardiac shadow, but the inferior border of the heart is actually not, the air is not there on the along the inferior border of the heart. And one may appreciate this lifting of thymus lobe, also called as a cell sign. So on lateral view also, one may appreciate that there could be retrosternal air collection, and then lifting of this thymus lobe. So basically, in normal neonate, there is no gap between the cardiac shadow and the thymus shadow. But in case of pneumomediastinum, this air is actually lifting the thymus lobe and basically creating a gap. So this is basically the cell sign. So next comes the role of point of care lung ultrasound. So as we saw that point of care lung ultrasound is quite useful either in the endotracheal tube position confirmation. This can be helpful in the diagnosis of air leak syndrome also, including pneumothorax. So in case of normal lung, one may find this pleural line and A lines. And on the B mode, and on M mode, one may find this sand on beach appearance. But while in pneumothorax, there will be absence of this lung sliding. So lung sliding is normally present in the normal lung, but this lung sliding will be absent. And one may appreciate this lung point. So lung point is nothing but a transition point between the normal lung, where you can find this normal lung sliding, and this is the area of air collection where the lung sliding is absent. On the M mode, one may find this barcode appearance because of collection of air between the collapsed lung and the pleural line. So there are various large RCTs and meta-analysis which have reported the preventive strategies to reduce this air leak syndrome. One such study is use of a high respiratory rate, more than 60 per minute, and it has been shown to reduce the incidence of pneumothorax by almost 30%. Using inspiratory time more than 0.5 seconds, that is long inspiratory time, is definitely bad in context with the incidence of pneumothorax. The use of pressure ticketed ventilation as compared to the controlled mechanical ventilation has not been shown to be useful. But the elective use of high frequency ventilation as a primary respiratory support as compared to the controlled mechanical ventilation is definitely bad, and it will lead to increase in the incidence of pneumothorax. There is no added benefit of routine pseudoanalgesia over synchronized ventilation. So this is not routinely recommended. The volume targeted ventilation has been definitely shown to be beneficial as compared to pressure limited ventilation. And it has been shown to reduce the incidence of pneumothorax by almost 50%, with the number needed to treat as 20. And similarly, in case of BLBW infant, the utilizing of optimal humidification and inspired gas provision at more than 36.5 degrees Celsius has been shown to reduce the incidence of pneumothorax by almost 2/3. What about surfactant? So early rescue regimen, that is administration of surfactant within first 2 to 3 hours of after birth, is definitely shown to be beneficial as compared to delayed surfactant. It can reduce the incidence of pneumothorax by almost 30%. The multiple dose of surfactant is more beneficial as compared to the single dose of surfactant. Similarly, the use of early surfactant with brief ventilation as compared to the surfactant and continued ventilation is more beneficial, and it can reduce the incidence of pneumothorax by almost 50%. However, the use of prophylactic surfactant has not been shown to be beneficial, and it is actually increasing the incidence of pneumothorax. So this is not recommended routinely now. So this slide shows the suggested ventilator strategies. So whenever indicated, we should use early rescue regimen of surfactant administration within first 2 to 3 hours after birth. If we are using volume targeted ventilation, then set the target at 4 to 6 ml per kg. But if you are using pressure limited ventilation, then also try to achieve tidal volume at around 4 to 6 ml per kg. After administration of surfactant, that period is actually quite important, and baby should be monitored very carefully, because there will be sudden change in the compliance, and that's why we should monitor very carefully in the post-admission administration of surfactant. The pressure limit should be around 14 to 16 in case of preterm, and 16 to 20 in case of term babies, and definitely avoid more than 24 centimeter of water, the PIP level. And if there is a requirement of mean airway pressure more than 12, then consider high frequency ventilation. PEEP should be around 5 centimeter, and it will be optimal. And we should always try to wean off to non-invasive respiratory support like CPAP as soon as the baby is stable. The respiratory rate should be around 40 to 60, as we have seen that using more than 60 actually is beneficial. Using that inspiratory time should be around 0.8 to 0.4 second based on the underlying disease condition, but definitely we should avoid inspiratory time more than 0.5 second. We should use optimal humidification, and inspiratory temperature should be around 36.5 to 37.5 degrees Celsius. Adequate anesthesia should be used, and we should always follow a written standard protocol for endotracheal tube care, including endotracheal tube fixation, suctioning frequency, and other things. So next thing is equipment failure. So on history, we may find that there could be history of frequent alarm or water in the circuit. There are several reports in which they have reported unexplained hypotension or hypoglycemia because of malpositioned central line catheter. So we should look for these conditions. On clinical examination finding, we may find poor chest movement or reduced sedentary on ventilator, but it will improve on TPIS TPIS resuscitator. The charts may display that there was some concern over the ventilator. Blood gas may be absolutely fine before the acute event, and the graphics may show obstructive pattern if there is water in the circuit or interference in the flow waveform because of water in the circuit. X-ray, if we are suspecting the malpositioned central line catheter because of unexplained hypotension or hypoglycemia, then one may check for the central line position. And if one is not very sure in one view, either in the AP view, then one should look for the other view also, including lateral view. So this is a case report in which they have reported a misplaced PICC line catheter resulting into the contralateral pleural effusion. So one may appreciate the the PICC line catheter coming over here, and it is leading to the pleural effusion on the right side. And this happened actually within 6 hours after the insertion of PICC line. And immediately after removal of this PICC line, the baby improved as well as clinically as well as radiologically. So one large series has reported the incidence of PICC line related pleural effusion as around 0.4 per 1,000 catheter days. And this was actually a large series. The point of care lung ultrasound is quite useful in the position confirmation of the central catheters also, including either during the administration or after administration. Next comes the equipment patient in asynchrony. And on the history part, one may find there could be history of bad lung disease, or there could be history of recently reduced or stopped sedation. After that, baby is quite active on clinical examination finding. There could be variable chest movements, and there could be variable intercostal and subcostal retractions. Charts may display rising of I2 requirement, multiple desaturation episodes, high blood pressure or tachycardia, and pain score may be increased. Blood gas may be quite variable. In the pulmonary graphics, one may find normal to high resistance and the features of over distension on the pressure volume loop. There could be either excessive or inadequate triggering also. On X-ray, one may find significant lung disease and the features of hyperinflation. So there are various measures to improve upon this asynchrony. So always set your trigger sensitivity at adequate level. Keep your flow sensor clean and free from dust and water, and use optimal humidification. Avoid clogging and secretions in the endotracheal tube. Suctioning should be as and when required, and always use optimal humidification. So in summary, we may find that endotracheal tube position will be changed in case of extubation, but will be unchanged in other conditions. The pressure waveform will be regular in most of the conditions except for the equipment failure, where one may find the reduced this pressure waveform. The flow waveform will show only inspiratory pattern in case of extubation, but in most of the other conditions, the flow waveform will be reduced. And in oscillatory findings, one may find the reduced or absent breath sounds in most of the conditions. So comparing the graphics, this is a normal graphic, normal ventilator graphics, where you can see that there is the normal and regular pressure, flow, and volume waveform. In case of blocked endotracheal tube, one may find that the pressure waveform will be regular, but the flow and volume waveform will be reduced in size. And on display, one may find reduced axial tidal volume and the minute ventilation. If there is a problem with the circuit or ventilator, then all three waveforms will be irregular. And if there is accidental extubation, then one may find that the pressure waveform will be regular, but in the flow waveform, there will be absent expiratory flow, and there will be 100% leak in the volume waveform, as we saw in the first case scenario. So the suggested algorithm for these conditions, whenever baby is put on mechanical ventilator, anticipation should be started as soon as the baby is on mechanical ventilator, and we should anticipate all the acute and long-term complications. Whenever there is acute desaturation and bradycardia episode, then do bedside assessment, including historical aspect, clinical examination finding, getting the trends from the monitors and the pulmonary graphics, the recent blood gas values, and X-rays. Follow a systematic approach, and the bedside action should be in parallel to the bedside assessment. So if there is a requirement to suction, then suction endotracheal tube, adjustment of endotracheal tube may be required, or the trans-illumination test. And after reaching to a diagnosis, whether this is because of either respiratory event or because of non-respiratory event, one may manage accordingly. So this is a suggested algorithm for the management of these conditions. Last thing is alarm, which is part and parcel of the systematic approach. And we should always set our alarm appropriately, and we should always respect the alarm. So this should never be ignored. So there are few examples of alarms, like if the minute volume is low, then this could be either because of disconnection or large leak in the circuit, or this could be because of either lack of respiratory drive, because of worsening lung disease, or complete endotracheal tube block, or could be because of splinting also. If the minute volume is high, then this could be either because of incorrect weight entered, this could be because of change in the lung compliance or inappropriate mode, or because of auto triggering. If the respiratory rate is low, then this is because of either poor respiratory drive or splinting or blocked tube. Or if this is high, then this could be because of false triggering, because of either water in the circuit, or you have set the high backup rate, or there could be seizures also. In case of flow sensor alarm, this could be because of water in the flow sensor, or could be because of mechanical failure or damage to the flow sensor. Apnea alarm can be either because of displaced or accidental extubation, or this could be because of complete endotracheal tube block. If the set tidal volume, axial tidal volume is not reached, then this could be because of either you have set your Pmax very inappropriately low, or this could be because of worsening lung disease, or there could be significant leak or atelectasis. So what is the way forward? So the medical field has witnessed so many advances in the technology, but the delivery of evidence-based practice is quite below our target. There comes the role of this quality improvement initiative. And so this is basically need of the hour, and it can help in the reduction of the incidence of all these problems. Artificial intelligence is one other emerging concept, and NICU is also not untouched with this, and there have been many reports of artificial intelligence for many neonatal conditions. So this is one quality improvement study aimed at reduction of events of pneumothorax. This y-axis is because of is the number of patients per month. The white bar is number of patients per month. The black bar is basically the events of pneumothorax, and the x-axis is the timeline. So the authors actually introduced one standard clinical protocol for surfactant administration and the mechanical ventilation strategy. And after the implementation of this standard protocol, one can see that there was significant reduction in the incidence of pneumothorax. This is a Pareto chart for accidental extubation, the various risk factors for accidental extubation. And we can see here that 4 to 5 major risk factors actually are responsible for almost 2/3 of the total incidence of pneumothorax. So these major risk factors include agitation, endotracheal tube manipulation, bedside procedures, loose fixation of the endotracheal tube, and prolonged mechanical ventilation. So these are the major risk factors for accidental extubation. The interesting thing to note here is the nurse to patient ratio as one risk factor. So we can see here that this is just adding another 3% to the total incidence, so which is not very much significant. So this nurse to patient ratio is not very much significant risk factor for this accidental extubation. And this is quite relevant to the low resource settings, including ours, where the optimization of nurse to patient ratio is quite challenging. So we should focus upon these major risk factors rather than focusing upon the optimization of nurse to patient ratio. This is a busy slide, but we'll focus on the contents in the box. So if you are planning any quality improvement study in your unit for a reduction in the incidence of accidental extubation, the better marker should be number of unplanned extubation per 100 mechanical ventilation days because of rarity of these events. And the benchmark should be less than 1 unplanned extubation per 100 intubation days as a target, because 0 is actually unrealistic figure for this condition. And then we should, it is always good to have a standard written clinical protocol for endotracheal tube care, including the fixation, the securement, the constant vigilance, as well as the frequency of suctioning. And we should always follow the checklist protocol for readiness of extubation, in case, especially in the case of extreme preterm neonates. And the most important thing is we should try to avoid the duration of mechanical the increased duration of mechanical ventilation as soon as possible. So whenever the baby is ready, we should wean off to a non-invasive ventilation support techniques. This is another quality improvement study for aimed at reducing the accidental extubation, and they used they conducted several PDSA cycles by using several change ideas. We can see over here that this U chart is showing almost 16 change ideas. Some of these change ideas are the development of unplanned extubation bundle, including using the commercial securement device, or the use of the location of device, the size of the device, then the replacement of device every 7th day, then categorizing of the events as preventable or unpreventable, and use of various techniques of the endotracheal tube fixation. So one can see over here that the authors could actually able to reduce the incidence of unplanned extubation per 100 intubation days to 0.5 per 100 intubation days, and they could able to sustain it for a long period of time. We can see over here that almost for 2.5 years they could able to sustain it at the same level by using various several change ideas and multiple PDSA cycles. This is another quality improvement study in which they used a standard clinical protocol and ensuring at least 2 providers whenever there is a movement of the baby, and following the standard protocols for the head and airway position during chest ray acquisition, various endotracheal tube securing methods and depths, and the auditing of this unplanned extubation events to look for the various contributing factors. So one can find here that there was a significant reduction in the incidence of accidental extubation following these standard protocols. So artificial intelligence is another concept, and as I told that NICU is also not untouched with this. There are several neonatal conditions in which there are reports of utility of this artificial intelligence, including necrotizing enterocolitis, the prediction of birth asphyxia, detection of seizures, early recognition of sepsis, and prediction of respiratory distress syndrome. So this is one such potential area, this acute deterioration of a neonate on ventilator. This is one potential area because this requires systematic approach, and it involves many parameters, including historical aspect, monitoring chart, pulmonary graphics, ventilator settings, and monitoring trends. So many parameters are actually involved. So this is actually a potential area for artificial intelligence, and we hope that there will be some reports on this topic also. There are some unanswered questions also in context to the acute deterioration of the neonate on ventilator. So we have some evidence, but not foolproof evidence for some of these research questions, like whether one should practice nasal intubation or oral intubation in relation to the acute deterioration or accidental extubation. What should be the optimal method of securing, whether we should use any commercially available securement device or not, whether we should use cuffed endotracheal tube or uncuffed endotracheal tube, and whether it helps in the prevention of accidental extubation. The flow cycled and versus time cycle synchronized ventilation. This is although intuitively this seems to be helpful in the reduction of air leak syndrome, but in the study actually it has not been shown to be useful. And the frequency of suctioning, whether we should use as scheduled suctioning or as needed suctioning, although we practice as needed suctioning, but whether we don't have foolproof evidence for this question also. And we have at least some evidence for long inspiratory time, especially more than 0.5 seconds, which is actually has been shown to be increasing the incidence of pneumothorax. But still, we don't have enough evidence whether we should use what should be the optimal inspiratory time. So, putting the baby on mechanical ventilator is not free of complications, and this can lead to ventilator-associated lung injury. Some of these conditions can lead to acute deterioration of the neonate on ventilator. So, anticipation is the key management aspect, and we should always start anticipating the complications whenever we put the baby onto the mechanical ventilator. We should always follow systematic approach, as we have discussed, and utilization of newer technology is quite useful, including pulmonary graphics, ventilator trends, and other parameters. And the most important, always respond to the baby first whenever there is acute deterioration. So with this, I thank all the participants for the patient listening, and happy to take some questions. Thank you.
Thank you, sir. That was a wonderful presentation. And before going to the question and answer session, I would like to ask Dr. Amit Gupta to share his experience on this topic.
Thank you very much. I think it is fair to say that your lecture was an education because it was so nice to get an update of the latest and especially the QI initiatives that you talked about and how the accidental extubation rates had been cut by such a long time, such a long number, and also it was sustained. So I found it very interesting. I really enjoyed listening to the systematic approach. And first of all, I would like to say that this problem is not limited to a particular setting. It is very common in every setting. And as you said, the key thing is to attend the baby first. I think that's very important. And often people forget that. And there is a lot of distraction around alarms and bleeps and so on. And they forget to look at the baby. And I think that's something that's very important. I always say to colleagues and junior colleagues that when you go around the ward round, you've got babies in the incubator, take some time to look at a baby very well, because you get a detail of pattern recognition of what's normal, what's not normal. And you can often, pick things up before, because there is a particular way the baby looks when the tube is out and the retractions are there because there is air hunger. Sometimes you pick up these patterns just by visualization, but it's important to look at the baby. So that's very important. I was going to before I ask other people to take to do this, and before I ask Nishad, Dr. Nishad to talk, I was interested in, when these acute deteriorations happen, and one thing they said that, come in the morning and something has gone wrong. Now, there are two patterns. One is acute deteriorations leading to death or leading to sudden death tend to happen overnight more than they happen during the day. So there's more likely that there's more help available at the daytime. And I think there is a better recognition and a quick escalation of the problem during the day. That is one of my theories. I think that may be one of the reasons why the daytime these things are different. And the second thing is I think one of the factors that we mustn't overlook is how much time and energy do nurses have in maintaining vigilance, number one, especially in our setting when the nurses are stretched. Number two, how empowered do nurses feel in escalating something without fearing that they might be put into a spot. I think those are the two things which interest me immensely. And I say this with some interesting anecdotes because I was there in a hospital a couple of years ago in Chennai. And one of the doctors told me, because I saw the ET tubes were very long. ET tubes were very long. And I was asking, why are the ET tubes very long? Because, they should be cut short. And the answer was that often what happens is, if the tube comes out, the resident doctors are not able to put it back, or they are too afraid, not the tube coming out, the connection to the tube coming out. And the nurses are too afraid to then escalate it, or there's a delay in escalation and there is some death according to it. So they kept the tubes long because the connector, sometimes the nurses struggle to put it back. It was a small issue, but I think in our context, we have to understand the dynamics of how teams operate. And especially when you've got a problem, how confident does a nurse feel to escalate it, how much time she has to look at a patient and do the anticipation bit as per your talk. So those are I'm just putting it out there for people to chat and discuss.
Thank you, sir. Now I would like to ask Dr. Nishad sir to share his experience and how to go about this in Indian scenarios.
Hey, thank you, Vinay. Thank you, Chanchal, for that wonderful talk. I think I learned a few new things too, like Dr. Amit was saying. One of the things that I wanted to point out is that you mentioned a lot of things like ventilator graphics and other X-rays, other tools to find out what's wrong with the baby, in addition to careful clinical examination. The one point that residents often forget is that there is no substitute to spending time at the bedside. So every NICU will have its own set of equipment, ventilators, the information available on the screens are going to be different. Unless you spend some time at the bedside, you know your equipment well, it's going to be impossible to figure things out in an emergency. If you want to quickly analyze that information and make sense of it, then you have to be very familiar with that equipment. You need to know where to look to find what. So that is something that very often we don't do, unfortunately. We have had residents who don't know where the buttons are to look for loops, for example. So there is no real replacement to clinical medicine, spending time at the bedside, looking carefully at the baby, looking at the equipment. The other thing is clear communication between the team members when there is an emergency. Very often we hesitate to speak loudly, to communicate with each other very clearly ask for what we want to be done, ask people by name to do specific tasks in an emergency, like calling for help or getting you the right size endotracheal tube. So we don't often do that. And I think simulation to some extent can help with overcoming some of these things. But again, there are true emergencies, often enough and more in our ICUs. So those are also situations to learn. If that baby doesn't benefit, the next one might. So I think those should be takeaway messages for residents, that you should be at the bedside, and each of these events is also a learning opportunity which may help the next baby survive, even if this baby doesn't.
Thank you, sir. Now coming to the question and answer session, there are a lot of questions. First one is role of SBT, spontaneous breathing trial, in preterm neonates before extubation.
Yeah, so I'll take up this question, Dr. Binay.
Yes, sir. Yes, sir. Yes, sir.
We can see that in pediatric and adult literature, the role of SBT is there before extubation. But in neonate, actually, the evidence is not quite available for the role of SBT. Some people are actually using ET CPAP also. This should be actually should not be done. So SBT, like after emergence of this non-invasive respiratory support techniques, whenever baby is stable enough, then we may find that we may extubate to non-invasive support technique. But the role of SBT is not very much evident in neonate population. I would like to ask sir also if they can share their experience regarding this SBT, role of SBT.
Okay, so that's a good question actually, because there is some amount of discussion, and in almost every conference you see some abstracts about this. But really there is no strong evidence that spontaneous breathing trial helps. And one thing to remember is that the idea here is that it's kind of like electronic extubation. You have the endotracheal tube in, but very little support other than that. People use endotracheal CPAP, or sometimes with some automatic tube compensation or a small pressure support to overcome tube resistance. And that's the idea, that you can electronically extubate the baby. But very commonly, a reason for failure in our babies is some kind of obstruction, either a laryngeal edema or subglottic edema. Those things you will not know about until you pull out the tube. So even if you have done a spontaneous breathing trial, things can still go wrong, even if it went well. So that's something to keep in mind. Maybe that's the reason that at least randomized control trials haven't shown any significant benefit to this, using this as a diagnostic test. I think there was a fairly large RCT from Quebec last year, and they didn't find a difference. I don't remember what the outcomes they studied were, but as far as I know, there is no strong evidence to recommend a spontaneous breathing trial in preterm babies currently.
Uh, Going to the next question. What are the what is the preferable ET measurement? Weight plus 6 or weight plus 5 in Indian units? Uh, Sir, Chanchal sir.
Yeah, as per the recent NRP guidelines, this weight plus 6 is not there now. Like we should use naso tragus length and TL plus 1. We are using that one. I am not very sure about the Indian context because NNF has not updated our Indian NRP for quite some time. So we may find the actual answer once we get the revision or updation of this Indian NRP. But we are following NTL plus 1 as per the recent NRP guideline.
Chanchal, I think that question might have been because, again, a good question. I think the idea is that there is more intrauterine growth restriction among Indian babies. So whether we need to use shorter length. It does not matter that much in the sense that we have, until recently, we have been using the weight plus 6 measurement. And we don't find the endotracheal tube too far in very often, fairly uncommon to find it too far in. Actually, the opposite may be more common. Maybe because the growth restriction affects the weight more than the length of the baby. And the length of the trachea is actually more dependent on the length of the baby, not the weight of the baby. So, it's very often the weight is less. And what happens is when we do weight plus 6, you are actually using a smaller length of insertion. So it's probably the other way around, that the tube often tends to be very high. So weight plus 5 is definitely not the way to go. Weight plus 6 or the nose to tragus length would be better.
Sir, Amit sir, what would you be adding on this, sir? Means what you're following in UK in most of the times.
I think we offer. I don't think we have a problem with this with the formula. I think we still use the weight plus 5. I think so, but I may be wrong.
Okay.
I've just forgotten what we're currently using, but we use a chart. Veera is been recently in Oxford. He might be able to tell us what do we use. Sorry, I'm sounding very ignorant here, but I think we've got a color chart that we use. But I think so that's one thing, and it's very interesting the debate around what length, different lengths for the Indian context in terms of IUGR, and I actually would agree with Dr. Nishad that I don't think it will make much of a difference in terms of length. I don't think so.
Thank you, sir. Moving on to next question. What is the role of negative suction in pneumothorax? Chanchal sir.
Yeah, so if you look at the literature, actually there is not much evidence about this modality in case of pneumothorax. Many units are actually practicing this negative suction, especially for large pneumothorax, and especially when the chest tube is not draining. So one should look, and this is totally extrapolated from the adult and pediatric literature and evidence. So if you ask me, the evidence in neonatal population, it's not much foolproof, but some are practicing this one. If you want to use this negative suction, especially in the case of a large pneumothorax, and especially if the chest tube is not draining, then one may use this pressure at around 5 to 10 millimeter of mercury, not more than that, because that will lead to actually opposition of the pleura to the tube and will actually reduce the drain much more as compared to the previous one. But one should always look for the reasons why this is not draining. Even if there is large pneumothorax, why this is not draining, whether your tube is in position or not, or still there is some pneumothorax, or there is some blockage because of either fibrin deposition. So one can do this milking of this ICDT to relieve the obstruction. And basically, you have to look for the reasons for not draining, rather than considering a negative suction, which is actually not very much evidence based. But if you want to use, then definitely not beyond 5 to 10 millimeter of mercury pressure.
Thank you, sir. Sir, one more question. If a baby is ventilated and had a ICDT in situ, we should remove ICDT first or extubate first? This is a question from Neeraj Mishra. Chanchal, sir?
This is a quite interesting question. Actually, we face this scenario many times. So we are stuck whether we should extubate first or remove the ICDT first. One theoretical risk is there if, see, if you are ventilating the baby, then basically you are giving positive pressure ventilation. And once you have extubated the baby, then baby is actually breathing on its own. So there will be negative pressure in the pleura. So if you are, if you have removed the ICDT first, and if you have extubated first, and then you are removing this ICDT, so then baby will be breathing spontaneously. And if the hole is actually left, and this is quite large one, then baby may suck some air, and there will be recollection of air in the pleural cavity. But this is a kind of just theoretical risk. I think in most of the extreme preterm neonates, we are not making a large incision, and the tube size is also very of small lumen. So the incision is actually not very large. And if we are actually taking care of that that hole, then probably this theoretical risk may not create any problem. So either way, either extubation first, or basically if the keeping the endotracheal tube in situ is more problematic rather than this ICDT, because of various factors leading to ventilator-induced lung injury. So if the baby is ready for extubation, I think we should extubate first, and then either way, basically. So there is no theoretical risk if you are taking care of the hole properly. I think we may ask sirs also about their practice.
I agree, Chanchal. This Nishad here. So I agree that you shouldn't hold up one thing for a decision on the other. So you should extubate the baby when the baby is ready, not postpone extubation just because the intercostal drainage tube is not out. Because, like you said, ventilation is not without risks, and you shouldn't delay it just because there is an there's an intercostal tube in situ. And when it's time to remove the tube, you have some people clamp it, some people don't. But when you're sure it's not draining and you feel it's not required, you can remove the intercostal drainage tube separately. But these are different clinical decisions, and you shouldn't hold up one because you're waiting for the other thing to be removed.
Yeah, I would agree. But so just to clarify two things. One is the first question was about applying suction. So what we tend to do in Oxford is we don't by default apply suction. We just have the tube placed. By default, we don't do it. If it's a difficult collection and that it's not clearing up, then we might apply it. But as a standard, we don't apply suction on chest tubes. Number two, we tend to use nowadays. We don't use the incision technique. We use Seldinger. So we use these pigtail catheters for newborns, and I think that has made the fear of putting a chest drain go away to quite an extent, because it's no different from like you putting a cannula. It's not very different from that. You just put it in, you put a guide wire, and you run the tube over it, and it's a relatively less scary and easier technique to do. That's number two. Number three, what I would say is, as far as taking the chest drain out, we don't clamp the tube because we haven't seen any benefit of that, and often it delays the tube taking out. And more often than not, the chest tube is out before the baby is extubated, and this is simply because that's the way usually babies behave. You usually have a resolution of a pneumothorax far sooner than the baby is ready to be extubated. So that's usually how it is. But I would agree with what Nishad is saying, that if you've got to extubate, and if you want to delay taking the tube out in a few hours, that's absolutely fine. But our tendency is usually to take the tube out first. And the other thing which we don't do is we don't take the tube out and do an X-ray again to see if there's air collected. We don't see any point in it. I mean, the clinical condition of the baby should tell us if the FiO2 is going up, or if the baby is otherwise clinically misbehaving, then we might do another X-ray. But we won't do an X-ray to just check if there is air recollection, or the pneumothorax has disappeared completely, or there is a pocket left or not.
Thank you, sir. Sir, last question to chairpersons. This question is from Veerraghavan, sir. In some micropremies, often less than 25 weeks, who are ventilated for prolonged period of time, sudden desaturations with no other obvious cause respond to paralytic agents. The conventional teaching is to avoid routine paralytic agents. However, in such scenarios, as described above, paralysis usually works. So what could be the etiopathogenesis in such scenarios? So this is a question posted by Veerraghavan, sir.
So can I give the Oxford?
Yes, sir.
One?
Yes.
Yeah. So the
Oxford
is very simple. I think what we often fail to recognize is that the ventilator and baby interaction can be quite variable. And what we call as the baby is not interacting with the ventilator well, or there is resistance of the baby and they're not synchronizing well, very difficult to pick that up in very tiny babies, 24, 25 weeks. See, in a bigger baby, it's very easy to see the struggle, and you can see the baby's discomfort. In tiny babies, it's the tidal volumes of what, if it's a 600-gram baby, it's hardly 3.6 mils. And so that kind of war between the ventilator and the baby is not picked up by the eye very easily. And as the baby becomes slightly more mature, as Veera would tell you, that this is not a problem initially, but as the baby becomes slightly more stronger, you're talking about 7 to 10 days or 10 to 15 days, you will find that the interaction with the ventilator actually becomes, the asynchrony becomes more prominent. And sometimes you do get stuck in a situation where that asynchrony happens partly, and there is and if the baby is on the edge of its capacity, you might find that pulmonary hypertension is being triggered after a period of small hypoxia, period of hypoxia, and then the only way you get control over the situation is if you muscle relax the baby and you correct that. So that is anecdotally what we found. You'll have to do proper studies to see what it is, but our approach has been is to use this not as a first resort, but as a resort when you're stuck, and it often not in the first week. Usually, it is usually a problem in the second week.
Yeah. Thank you, sir. Sir Nishad, sir, would you like to add anything on this?
No, I agree. I mean, we don't routinely use paralytic agents anymore, but that doesn't mean they are of no use. So there is always an occasional baby, and the only way to find out if it works is unfortunately by using it. So it doesn't always work. We have an exceptional baby who is extreme preterm or severe pulmonary hypertension who sometimes responds, but half the time it still won't work. But you have to try it when you are really stuck.
Thank you, sir. One more last question. Use of steroids in prolonged ventilation in neonates after extubation. Chanchal, sir, would like to take it?
Like similar to other questions, again, we don't have enough evidence in neonate population. Routinely, it's not recommended to use steroid in the peri-extubation period. But if you find that there are multiple, extubation failure earlier, then probably you may think of giving one dose of steroid and dexamethasone. But definitely it's not routinely recommended even for the prolonged ventilation.
Amit sir, would you like to add anything on this, sir?
Completely missed that question because one of the nurses came into my office.
Oh, sir, I would be repeating, sir. Role of steroids in prolonged ventilation in neonates after extubation. Steroids.
So when you say once the baby is extubated?
Yes, sir, after extubation, role of steroids. If the baby had a prolonged ventilation.
No, I don't think we do that. I think we will use steroids to just get them off the ventilator, and then actually try to cut it down very, very quickly. Now, one thing is there that we very quietly we've started using a little bit more of budesonide through the in a non-invasive way, and we use it via the high flow machine as well. There is actually very little evidence for budesonide which shows categorically that it works, but that practice has slowly crept in. In a post-extubated baby who's been extubated following steroids, we tend to have these babies on budesonide for at least a couple of weeks. I cannot say for certain at all that makes any difference. So that's number one. But normally what we would do is we would give steroids only to get the baby off the ventilator. Now, how many babies do get steroids is an interesting question. So if I look at the data we've got from Oxford, less than 25 weeks, I would say that 70 to 80% end up with steroids. At least less than 24 weeks. 24, 25 weeks, you might have a bit of sparing. So it just reflects the degree of immaturity in those babies who are 22, 23, 24 weeks. And I would take this opportunity to tell you and just share this with you that the way a 27-week and 27 and 26 are quite similar. Moment you go below 25 weeks, you're looking at a completely different ballgame. So the immaturity levels, the mortality, morbidity, all of that shoots up quite a lot. And I think managing a 22, 23, 24 weeker is a completely different skill set. Not a skill set, but the completely different set of problems. Most of them end up failing any sort of non-invasive initial support. Most of them end up having a tube down their throats, 80 tube for about 2 to 3 weeks. Most of them end up with having some steroids. They're very high risk of neck. So it's a very different ball game when you look at the very, very tiny babies. So that's just a comment I had.
Thank you, both the chairpersons, Amit Gupta sir and Nishat sir, for chairing the session. And I would like to thank Chanchal Kumar sir also for a wonderful talk. And it's been already late. It is 9:35 over here. Would we be? There are no questions also. I think, can we end the session?
Yeah, thank you, Chanchal. Thank you, Vinay.
Thank you very much.
Thank you so much, sir. Thank you so much, sir.
And nice meeting you, Dr. Amit.
Thank you very much. And Dr. Chanchal, I really enjoyed your talk. It was really very good.
Thank you very much.
And I almost wish you had given it to some of our juniors when I listened to it, because it was very comprehensive, and I really enjoyed it. So, and thank you, Dr. Nishad. That was really a pleasure. And hopefully next time, in Hyderabad,
sure.
I'll definitely come down and see you.
Right. Okay. Thank you.
Thank you so much, sir. Thank you so much, sir. I'm ending up this.